Hello everyone, today we are discussing topic penetrating aortic ulcer and intramural hematoma. We have discussed the meaning of acute aortic syndrome in the form of aortic dissection, penetrating aortic ulcer, intramural hematoma, and aortic aneurysm rapid expanding or symptomatic and trauma. Penetrating aortic ulcer pathophysiology. Penetrating aortic ulcer is ulcerative lesion developed at region of atheromatous plaque penetrating internal elastic lamina, but not all penetrating aortic ulcer associated with atherosclerosis. Intramural hematoma is a spontaneous hemorrhage caused by rupture of vasovasorum inside the media. Penetrating aortic ulcer is differentiated from aortic dissection as regards etiology in the following point. Trauma is not contributing factor to penetrating aortic ulcer. Connective tissue disease, marathon dilution is not associated for penetrating aortic ulcer. Penetrating aortic ulcer is not necessary to occur at the point of the most hydraulic stress as the lateral wall of the ascending aorta or ligament arteriosum of the descending aorta. But in case of the aortic dissection, trauma is a contributing factor for the aortic dissection. Connective tissue disease has a strong association with the aortic dissection, and it is most commonly at the point the most hydraulic stress at the lateral wall of the ascending aorta or ligament arteriosum of the descending aorta. Penetrating aortic ulcer. Brief facts. Patients with severe systemic atherosclerosis rarely has malperfusion in comparison to aortic dissection. Cause of the most secular aneurysm with the risk of rupture. Located in the arch and descending aorta. Often multiple, therefore surgical treatment is difficult. Is meaning here open surgical treatments. Differential diagnosis of the penetrating aortic ulcer mycotic aneurysm, which is presented with the systemic response of the fever, leukocytosis, tachypnea, or tachycardia, and the radiographic finding of the surrounding phlegm with stranding on imaging representing infected fluid or tissue. So the penetrating aortic ulcer is commonly and strongly associated with atherosclerosis, rarely presented with malperfusion in comparative to aortic dissection, presented more with sacral aneurysm and hazards of rupture, and located at arch and descending aorta, often multiple in number, and differentiated with mycotic aneurysm. Mycotic aneurysm has a systemic response of fever, leukocytosis, tachypnea, and tachycardia, and has a characteristic radiological finding of phlegm with stranding on imaging representing infected fluid or tissue. Intramural hematoma. Spontaneous hemorrhage caused by rupture of vasovasorum inside the media. Difficult to be differentiated from thrombosed aortic dissection. Can proceed to classical dissection by percentage of 60 to 47%. Long time to diagnose and usually overlooked. What about the combination of the penetrating aortic ulcer and intramural hematoma? If you have a case of combined penetrating aortic ulcer and intramural hematoma, it has a strong liability to progress for aortic dissection. Hematoma is focal without much extension and more liable for rupture and require urgent treatment. So we have discussed intramural hematoma. It is a hemorrhage inside the mediated rupture of vasovasorum, and it is difficult to differentiate it from thrombosed aortic dissection and can be proceed to classical dissection. And if we have a penetrating aortic ulcer and intramural hematoma, that means it is more liable to progress for aortic dissection, it's more liable for rupture and may require urgent and difficult treatment. And hematoma is focal without much extension. Here we have a case of intramural hematoma and penetrating aortic ulcer. Intramural hematoma, and we have here penetrating aortic ulcer. In this one. penetrating aortic ulcer and intramural hematoma. This is the axial one, and this is the coronal gland for the CT angiography, and we have intramural hematoma and penetrating aortic ulcer. Okay, the incidence history of smoking of coronary artery disease, COPD, and hypertension, atherosclerosis, male 7 to 8 decade of life, concomitant associated with aneurysm and peripheral artery disease. Clinical picture asymptomatic, especially abdominal type, symptomatic, especially thoracic type, chest pain radiate to back or abdominal pain is like aortic dissection, hemoptysis, hematemesis in case of erosion to the surrounding bronchi and esophagus. Rupture more than malperfusion in differentiated with aortic dissection, equivalent peripheral pulsation in both upper limb and lower limb in comparison to aortic dissection. In case of aortic dissection involving left subclavian artery, we will not have equal pulsation at both upper limb. When the dissection involves one of iliac artery, also you don't have equal pulsation in both lower limb. But here in the penetrating aortic ulcer or intramural hematoma, we have equal peripheral pulsation at both upper limb and lower limb. We have risk of rupture more than perfusion. Pulmonary and respiratory complication, enlarged hemothorax and effusion and distal embolization. So the penetrating aortic ulcer at male gender, 7 to 8 decade of life, history of the smoking, had COPD and hypertension, which is the same risk factor of atherosclerosis, concomitant association with aneurysm and peripheral arterial disease. Clinical picture asymptomatic in the abdominal type, symptomatic in the thoracic type, chest pain radiate with back or abdominal pain, hemoptysis and hematemesis in case of erosion to the surrounding of bronchi and esophagus, rupture complication more common than malperfusion of the peripheral limb ischemia, visceral ischemia, and renal manifestation and neurological manifestation, equivalent peripheral pulsation at both upper limb and lower limb in comparative to aortic dissection, pulmonary and respiratory complication in case of a rupture inside the pleura, enlarged hemothorax and effusion, and distal embolization. Diagnosis for penetrating aortic ulcer and intramural hematoma. Number 1, CT angiography. It can assess the aortic wall enhancement, thrombosed intramural hematoma external to calcified intima. Contrast filled catheter-like ulcer and outbouching of the endo-luminal border in case of penetrating aortic ulcer. Contrast extravasation through the ulcer, absence of the double lumen which is differentiated from the aortic dissection, transmural rupture, and measurement of the ulcer dimension, that means length and width and the depth. So CT angio can detect intramural hematoma in the form of aortic wall enhancement and thrombosed hematoma external to calcified intima. Can detect penetrating aortic ulcer in the form of contrast-filled catheter-like ulcer and outbouching of endo-luminal border, or contrast extravasation through the ulcer, absence of the double lumen which is differentiated from aortic dissection, transmural rupture, and measurement of the ulcer dimension in the width and length and depth. So this is a typical illustration of penetrating aortic ulcer. We have here focal outbouching of the contrast separating extensive intimal calcification. So there is catheter-like ulcer, outbouching ulcer of contrast, and separating extensive intimal calcification. This is the picture of penetrating aortic ulcer. We have outbouching contrast, and we have here calcification of the intima, outbouching contrast, and this is form of the sacral aneurysm. So this is penetrating aortic ulcer of the descending aorta. Intramural hematoma. Axial non-enhanced CT angio show intramural hematoma involving the ascending aorta, and communicating dissection involving the descending aorta, black arrow, and we have here small intramural hematoma is also noted at left lateral aspect of the proximal descending aorta. So this is the non-enhanced CT angiography, intramural hematoma at the ascending aorta, intramural hematoma at the descending aorta, and this is the flap of a dissection. And here we have axial enhanced CT angiography with a contrast. We have a classical infimomedial flap dividing true and false lumen in descending aorta. We have a high attenuation intramural hematoma is less obviously detected, and intramural hematoma is seen along the lateral wall of the false lumen. So the axial enhanced CT angiography show classical infimomedial flap of the aortic dissection. We have high attenuation intramural hematoma is less obvious in this one, and we have intramural hematoma seen along the lateral wall of the false lumen. MRA detection of a penetrating aortic ulcer, the same finding of the CT angiography, catheter-like ulcer, absence of the intimate flap or false lumen, and the aortic wall appear thickened with high intensity signals on T1 and T2 when complicated by acute intramural hematoma. Transesophageal echo catheter-like ulcer, raised edge, and it could also evaluate the cardiac function, regional wall motion abnormalities. But we don't have a specific finding for the intramural hematoma or penetrating aortic ulcer in case of TE transesophageal echo. But you can find catheter-like ulcer, raised edge, but not every case will have the same finding. So it's not specific and doesn't have a high sensitivity in the diagnosis. BET associated inflammation and marker of aortic wall instability. This is a picture of a transesophageal echo, and you can detect here what's called mural thrombus. We have here mural thrombus, and here we have aortic ulcer, and here we have localized aortic dissection. So hematoma or thrombus, aortic ulcer, and localized aortic dissection. Treatment, the goal is to prevent the rupture. So conservative treatment for asymptomatic controlled blood pressure patients. Intervention for symptomatic uncontrolled blood pressure, refractory chest pain, contained rupture, expanding intramural hematoma, or evolving aortic dissection, distal embolization, pleural effusion, and other complications. It is indicated for treatment in case of aortic diameter more than 6 cm, 60 mm, and the measurement of the penetrating aortic ulcer more than 20 mm in length and width. So the goal is to conserve and prevent the rupture if the patient is asymptomatic and his blood pressure is controlled. But what about if the patient presents with uncontrolled blood pressure, refractory chest pain, contained rupture, expanding intramural hematoma, evolving aortic dissection, distal embolization, pleural effusion and rupture, and other complications? Definitely it is indicated. Aortic diameter more than 60 mm indicated. Penetrating aortic ulcer measured more than 20 mm in the width and length is indicated. So how we can treat them? CVAR has a good result in short and mid-term, but long term is not evaluated yet. Less morbidity and mortality in comparison to open, but with high incidence of re-intervention. Limitation by landing zone, proximal aortic pathology, proximal to branches of mesenteric vessels, and steep aortic angulation. Oversizing is 10%. Ballooning inside the endograft only. Complication, the usual complication of the TVAR are stent migration, hanging, fracture, infection, and spinal cord ischemia. Open, we have risk of general anesthesia, large incision, clamping and unclamping of the aorta, possible cardiopulmonary bypass, and extended hospital stay, and post-procedural complications. The European Society of Vascular Surgery guidelines for the penetrating aortic ulcer and intramural hematoma are the following. Uncomplicated type B intramural hematoma and penetrating aortic ulcer should be treated medically and followed by serial imaging surveillance. Endovascular repair should be considered for complicated type B intramural hematoma. Endovascular repair should be considered for complicated type B penetrating aortic ulcer. and this is the reference, and thank you very much for your attendance.